microphone. While we're waiting for that, I'm going to ask Rachel the first question. So you presented two abstracts from different VA settings. Gupta's study where, if I got it right, 75 to 80% of colonoscopies were excluded, many of which because there was an inadequate report, others because there was no comment on bowel prep. So kind of tells us something about that. Other from a very selective VA population, I think, with probably really good endoscopists, really good reporting, where the adenoma detection rate overall is over 50% for every colonoscopy, which kind of brings the question up, are we really doing a good job risk stratifying patients if the surveillance patients are exactly the same as the screening patients? But that's not really my question. I guess my question is, do we need, because that has such great external validity, would it be fantastic if it was true, easy to implement for practice, because we all know from Corley's study that adenoma detection rate is clearly the thing that's associated with outcome for patients, so probably our best marker of quality. And it would be nice to be able to do that more rapidly with a database for people in practice or in group practice or individual. Do we need to validate it somewhere like TPMG or somewhere else and see if that's true?
Yeah, absolutely. And you raise excellent points. I think, one benefit of the VA health systems is the fact that they have data that, goes back for many, many years. And so when you're looking at Samir's study, for instance, and wanting to assess a history of procedure and what was found, and then getting all of those sociodemographic factors, you're able to do so. And that's really important when creating those types of prediction models and even determining ADR, as Tanya's group did. It's absolutely relevant and important that we're able to replicate these studies in, other similarly integrated health systems as well as others that aren't, including, safety net health systems. And so I think being able to replicate those studies in those settings and then determining their performance in different patient populations will really determine how much these new measures become incorporated in our day-to-day practice or don't. I think if we're able to do so, then we could very well see calculators like the e-prognosis, where you might go in and just plug in yes, no diabetes, age, last procedure was found, and then potentially get a more specific recommendation on follow-up, as well as help health systems better track quality metrics like ADR.
Perfect, thank you. Dr. Lon.
Yeah, I'm sorry. So when are we going to move from ADR to polyps per colonoscopy? Because the ADR is clearly something invented to protect endoscopists from inadequate, basically, why don't we move to polyps per colonoscopy as a measure of quality rather than this percentage of adenomas, in screening colonoscopies. I really enjoyed the fact that when they compared surveillance to screening, the quality measure was about the same. So, my ADR is over 70, 80%, but I'm at the VA. So 10 polyps per colon is a normal finding on it for me.
Want me to start?
So I think the question is number of polyps per colonoscopy rather than just simple ADR.
Yeah, no, you're bringing up a huge debate in our field. So ADR is definitely an imperfect measure, and in many ways you can game an ADR. You find one ADR, you find one adenoma in your colonoscopy, you can withdraw in 2 minutes and be done, and you can maintain your ADR. So there have been a lot of different measures that have been offered. In particular, there's one that's a measure called ADR plus, which is going to look at your total number of adenomas per colonoscopy rather than have you benefit from this gaming potential of just finding one and being done for that patient. And now we have to realize that it's also not just about adenoma. We know, especially with large sessile serrated polyps, that the risk might be even higher in certain populations of patients. So in our group, we've started to measure what we call SDR, which is a sessile serrated detection rate. And then there are also groups that are looking at overall polyp detection rate. But the bottom line is, if it's a rate and you are getting a point for any one, you can game the system, and we probably do need to control these measures by the number of adenoma or high-risk polyps in each patient that you are scoping. I hope that's helpful. I think it's going to evolve, certainly.
Next question.
Hi, Kayvon Dolachny, a GI pathologist down here in Orange County. It's actually pretty similar to the last question, but we generate reports all the time for adenoma detection rates for the doctors we work with. And I've always been wanting to do the sessile serrated adenoma detection rates, the SDRs, like you've said. I've read around somewhere in the 5 to 7%, but do you see utility for this moving forward for generating these reports for people?
Do you want me to go? Yeah. Certainly. I'm actually thrilled that you're here, and I might try and find you afterwards. So I work I work in a quality improvement team, and we actually have 2 pathologists on our team. I've learned an extraordinary amount about pathology that I think has really influenced how we look at these reports. We are not right now at all holding ourselves accountable for large sessile serrated polyps, and we need to be doing. And actually, some of the first studies that have been looking at sessile serrated polyp detection in addition to ADR are starting to roll out now. I saw one in gastro last year and one in GIE this year. So I do think there's going to be utility in that. I think there's going to be increased focus now that we're recognizing that there's an alternative pathway from the sessile serrated polyp to carcinoma that is equally important. So I would suggest keep doing that, and I'm curious to talk to you more about that.
And I would add, I think, the paper that would sort of guide us would be something similar to what Coralie published on the adenoma detection rate, right? Where we sort of know what that cutoff is for that quality metric that really impacts mortality. We don't have that information yet. And I would say that, I'm glad to hear what you're doing, and, many others in the room are tracking this, but there are many practices around the country that aren't even tracking this at all. And so I think the first thing we need to do is, how can we create uniform quality metrics for our entire profession, and then how can we then study that data to come up with metrics that make sense.
Yeah, I think Rachel's absolutely, Dr. Issaka is absolutely right. We're friends, as you can probably tell. I think that is absolutely right, and I think the problem right now is that no one's measuring it. But there's also a problem with the sessile serrated polyp in that often the reads are confusing. So even getting a pathology division to consistently label them as sessile serrated polyps is a challenge. Is the first challenge for that group of polyps. You're right; it's 3 to 7% of polyps. It's a small group, but we probably have to get the histology reporting systematically done, and then, as Dr. Issaka was mentioning, making sure that all health systems are reporting this out. And with that data, I think we'll learn a lot more about how all of these polyps are behaving.
So I think the really big news was the USPTF and early onset cancer, and I think you summarized a lot of the issues there. Increasing incidence, but still low. I think in some of the other abstracts that were covered, we know, and from other data, that people who really need to get it, who have a much higher incidence, still aren't getting colorectal cancer screening. You guys have been active along with others in showing us disparities and ability to get the tests and other barriers to care. So I'm wondering if you think for this age group, if in a perfect world, because also there's seems to be a left shift with the younger ones, whether FIT and Flex-Sig or maybe methylated septin-9, something else, might be the way to overcome some of those access problems in the immediate future.
So we know that with this change in age, that there are now 20 to 22 million Americans that are now newly eligible for colorectal cancer screening. Certainly, endoscopy capacity is local, but I know where I practice, we don't have the capacity to absorb all of those who are eligible for colorectal cancer screening now based on these new guidelines. So I think we will absolutely need to increase the non-invasive test use in this population. And, we're seeing more data in the areas of personalized colorectal cancer screening data. So, taking into account personal habits. We know that, there is an association between obesity and colorectal cancer. So is that present in that individual? What other risk factors might increase or decrease their risk for having polyps? And certainly taking all of those into consideration and then using these non-invasive tests, I think, will be really useful. As we do so, though, we need to track this information and study it because, perhaps the answer is you do non-invasive tests for the first 2 years and then you move to endoscopy, or perhaps it's flipped. We just don't know those answers yet.
I was just going to add, I agree completely, and I think a lot of systems are going to be embracing non-invasive tests for younger people. So I've seen already many health systems that have campaigns that they're automatically sending FITs to people who are 45 to capture them, to get them conceptually into this concept that they are now eligible, and also to capture them into the pool of people that they're screening. We certainly can't give everyone a colonoscopy, and we know from many people's research that a lot of people don't want a colonoscopy. So it's really embracing the reality that we have to use a multimodality approach if we want to get to 80% of the population screened, and we can't rely specifically on colonoscopy.
And I think the flip side of that is the conversation that no gastroenterologist seems to want to have, which is when to stop colorectal cancer screening, and in particular how they document it. I think there was an abstract at DDW, I forget the author, about whether or not that conversation was documented, or there was a discussion about potential risks and benefits for, say, the 69-year-old woman who's coming in for a colonoscopy. She maybe had a polyp 20 years ago. She's had 3 colonoscopies, no other risk factors, has some coronary artery disease, some diabetes, hypertension. And do you record it in the chart at that time, have the conversation then? Do you bring them back in 10 years? What's your documentation approach?
Yeah, so there is a big problem with lack of documentation for individuals who fall into that group of 76 to 85, and that's the group where we're selectively screening, right? So I think it's important to have these conversations with patients at the conclusion of their last screening test, because the reality is that many patients need to think about it. So if you wait until they're 84, or you wait until they're at the time of the next due test, sometimes things just fall to the wayside and never get done, and then they're 85, and we certainly aren't screening at that point. So the earlier that we can start having discussions with these patients, the better off I think we are, and the more that we can document these discussions, and also changes over time that happen in the interval between screening tests is going to be important. And that's not just at the older end of the spectrum. So we're starting screening at 45 now. We need to start talking to our patients at 40 to let them know that in the next 5 years, this is a reality for them, that they're going to need to be screened for colorectal cancer. Here are the options. Start thinking about what's going to be the best option for you. We know that it takes time for patients to make these decisions.
And I would add to that, there was a great study by Andy Chan's group out of Harvard. It wasn't presented at DDW explicitly, but recently in JAMA Onc, where they looked at older individuals who were completing colorectal cancer screening and showed ongoing benefit. The challenge was in that particular study, older adults with any underlying coronary artery disease, diabetes, strokes, were all excluded. And we know that our older patients are likely to have these comorbidities. And so I think we sort of have to have these conversations, with individuals who have these conditions. But there is a larger problem around health numeracy. And just because somebody is literate does not necessarily mean they understand the percentages that we share. And so now with screening ages changing in general, I totally agree that this is an opportunity to do more education around numeracy. Like, what do these numbers actually mean, and what does that level of harm mean for you? Because I can tell you, my own grandmother, who just turned 90, when she was 85 and was told didn't need to be screened anymore, she was like, absolutely not, give me my colonoscopy. So I think we have a lot of work to do around education.
Yeah, and it's really interesting because there have been studies on both sides of that. There have been studies that show the 85-year-old who says, bless you, I never want to have a colonoscopy again. I'm so happy I'm done with that. And then there's another group of people who say, no, give it to me anyway. I'm not passing up on this preventive opportunity. So it is very individualized to the patient. What did she get? Did she get the colonoscopy?
No, we talked about it.
Good for you.
It's a good granddaughter.
Yeah. Thank you both so much.
Thank you.
Okay, unfortunately.